but welcome tonight to this webinar. We're going to start with thyroid. So when you look at thyroid, keep in mind that there are probably 90% of the cases of thyroid that are running around out there are not going to be diagnosed through traditional medicine. They're not going to be diagnosed simply because if you're only looking at TSH, then you're going to miss a bunch of these cases. So I want to do something really briefly to give you some ideas when we look at thyroid, give us a few hints on how we can actually make this work out. Okay, so let's start over here from the top. You guys, I'm making your eyeballs go sideways, so sorry about that. Okay, so first off, if you have a pen and a piece of paper and you want to draw along with me, if you've never done this before, this would be a great experience for you, because guess what? I draw this cycle out every day in my clinic. You know, I'll have maybe 15 to 20 patients in a day, sometimes up to 25. But I can assure you there's not a day that goes by that I'm not drawing this cycle out to some degree. So one of the things that I find when you draw things for patients, they can really kind of grasp it better than you just talking or even showing them charts. Okay, so number one, we have the brain sitting like this. And number two, there's the nose and the mouth. Here's the brainstem. Down here is the thyroid. The first point I like to make with my patients is this. I like to make sure they understand that the brain is what controls the thyroid. It's regulating it. So in other words, the thyroid gland lives right here, but it can't think for itself. It's only going to do what the brain tells it to do. And it tells it what to do by way of what's called, and as we recognize, as the HPT axis, which is the hypothalamic to pituitary thyroid, and the pituitary is going to kick out TSH. So that's kind of the main marker in traditional medicine that is used to determine whether you have hypothyroid or not. Now, as I said, 90% of the cases or so, somewhere in that area, are going to be secondary, tertiary, and low functioning thyroid for other reasons. So when we look at what comes out of the thyroid, somewhere about 80% of what comes out of the thyroid is something called T4. Now, T4 is not the usable form. It's the form that your body uses as a transportation mode. So in other words, when you make T4, it has a half-life of about 2 weeks. So once it gets out into the system, you can use it for 2 weeks before it's really no good. And I'm going to draw the structure out here just a little bit. So here's a 2-ring structure, and that's what the thyroid molecule looks like. And it has 4 iodines coming off of it, and that's why it's called T4. We talked a little bit about this before. Then you have an enzyme that's called 5' deiodinase. You guys have heard of this before. It's going to take that iodine. It's actually iodide. Takes that iodide off, makes it T3. T3 does this. Inside every cell, we have a DNA, and there's a little receptor that comes off the DNA. There's only 2 hormones that go directly to the DNA. That would be cortisol, and that would be thyroid. Estrogen, testosterone, insulin, other hormones such as these, they have receptors on the cell membrane, but not the DNA, right?
Hey, Dr. Rob.
Yes, please. Let's roll on. This is going to be a lot more fun, like with the slides. So, and as I said, you know, we're going to go through a few case studies here, and I want to go through this from the perspective of a chiropractic internist. And I think Dr. Nett just alluded to that the DAPSI program, that's really what that is, Diplomated American Board of Chiropractic Internists. So we're chiropractic internists when we have this designation. So that's what I'm doing. I'm going through this from this perspective. Let me say something real quick about chiropractic internist. Chiropractic internist is really 2 words, and both of those words are very important. A chiropractor, as we know, has a philosophy that the power that made the body heals the body. Chiropractic philosophy is that the body heals from above down, inside out. The chiropractic philosophy is a vitalistic philosophy, saying that we don't fix the body, but we do things so that the body is in a better position to heal itself. And that's the chiropractic principle, if you will, in a nutshell. I mean, you can get more depth of that, but that's pretty much, a 10,000 feet in the air kind of look at it. If you look at an internist, internist is somebody who's going to take on all patients, all ages, both sexes, all conditions, and if they're not the person providing the care, they're the hub of care, so they direct care. So that's what I do. I have patients come in. I have lots of patients coming in with diabetes, cardiovascular disease, thyroid problems, even cancer, and different things like this that we're working through. So when a patient comes in, my job as a chiropractic internist is to apply the principles of above, down, inside, out. And I think this gives us a leg up with people who are trying to do functional medicine that are medical doctors or have a different paradigm of thought, because you can do this work, I think, much better and much more efficiently if you understand the chiropractic principle. So that's one thing. So when people come in, I am the primary care provider for that patient. I'm the one who, if they need to have an MRI, I'll send them out to an MRI. If they need to be referred out to somewhere, and I'll do that, but I haven't lost that patient. I'm just referring them out for this, that, or the other. So that's really what the chiropractic internist, and that's what this program is really about. Now, for the webinar, I just wanted to give you a little taste of some of the things that we actually do. And as I said, this is going to be a lot more fun, when we actually have the slides now. So let's get started here. One of the things that we talked about, now I'm going to briefly, go back through this because we've already done this, and I don't want to say the same things over. Let me talk a little bit about thyroid. And the very first thing that let's say about thyroid is this. And if you do have a pen and paper, please do engage with this. Okay, so number one, when somebody has a thyroid issue, there are a few symptoms that are going to be pretty commonplace. Number one, they're going to have fatigue. Can you see that drawing there, Dr. Annette? I just want to check to make sure.
Yes.
Okay, very good. And they're going to have issues with weight gain, or they can't take weight off, even though they're on a low, they're not eating much and they're exercising, they're doing all the things, but they just can't lose weight. Number three, brain fog, and this is actually common. Now, not to get too far into this, but in the brain, you have something called, well, I'm already into it, so let's do it. Okay, in the brain, here's the brain right here, and here's the nose and the mouth. Inside the brain, down here in this temporal lobe, you have something called the hippocampus. The hippocampus, as you know, is that place that helps you consolidate short-term memory to long-term memory. So that way, somebody says, hey, my name is Bob, my name is Ben, my name is Mary, you can remember that, or you go to the kitchen, you can remember why you went to the kitchen, or you can have a conversation and you remember what the train of thought that you're following. If you can't do that, that's kind of a brain, that's called brain fog. Now, the hippocampus is responsible for you. If it's healthy, you're not having that. Okay, so one of the killers to the hippocampus is too much cortisol. When somebody has cortisol surges, it can really damage the function of the hippocampus. That's the reason why people with hypoglycemia, when you have hypoglycemia, your blood drops, your brain sends an alarm to the adrenals to kick out cortisol so you can quickly get sugar to the brain. And when you get these cortisol surges, this is going to cause the hippocampus not to be happy. When it's not happy, you have brain fog. Well, another thing that can happen is this, is that acetylcholine is a neurotransmitter in the brain, and it provides speed to the brain. That's what gives the brain that processing speed, our ability to do things in the brain, our ability to consolidate memory and all kinds of different functions. Well, as it turns out, you need thyroid. You need specifically T3 to help you make acetylcholine. So if you're low in T3 or low in thyroid function, you're going to be low in acetylcholine, and that hippocampus is rich with acetylcholine receptors. And so if you don't have enough acetylcholine running around in the noodle, then the hippocampus is going to suffer. And that's the reason why a very common symptom for low thyroid is simply going to be brain fog. Another one we can see will also be constipation. Now, I don't always see this in patients because there can be other factors that block them from having constipation. But in general, if you have low thyroid function, it's going to slow down the bowel movements. So you're going to see this. So these are really 4 of the top common presentations as far as when somebody comes in, they're going to say, I have brain fog and I can't lose weight and I'm fatigued all the time and I'm constipated. You hear that, your ears are going to perk up and you're going to say, hey, this could be a thyroid case. And that gives you a leg up because when you do the history, rest of the history, when you do the physical exam, you're going to be looking for things which I'm going to go through in just a moment. Okay, so now the next thing is I went through before I got cut off, I was going through how to draw through the thyroid cycle. So I'm going to take a moment and do this. If you guys can get a piece of paper and draw along, here's the brain, the nose, and the mouth, and here is the brain stem, and here's the thyroid. Okay, so the thyroid kicks out T4. T4 is a 2-ring structure like this, and it has 4 iodide. It's not really iodine, it's actually iodide. It has 4 iodides coming off of it. I'm going to draw my finger here. So, okay, so that's 4 iodides. Whoops, sorry about that. Let's get back. 4 iodides. Well, okay, so that's good right here. Okay, 4 iodides. Now, as I said, T4 is there for transportation. You have that 5' deiodinase. It goes to T3, and then T3 lands on the DNA. Now, the thing about it is that's really important when we look at the DNA is this. Think about this. What does the DNA do? The DNA does one basic, simple thing. It makes proteins. And depending on the cell, if it's a liver cell, it's going to make proteins that are consistent with liver cells. If it's a brain cell, it's going to make proteins that are consistent with brain cells. Well, in order to make mitochondria, these energy packets in the cells, you have to be able to make proteins. So that's really one of the reasons why when people have low thyroid, they're not making proteins well enough in the cell, and they're going to make less mitochondria. But not only that, but they're just going to have less of everything in the cells. The cell's not going to function as well. This person's going to be tired. And the T3 and the T4 feed back to the brain. As I was saying before, the brain is what's controlling the thyroid function. So the hypothalamus gets the feedback. The pituitary, sorry about that. The pituitary gets the feedback, and then accordingly, they will send out the message of TSH. And just to reiterate, this is the reason why that many people come to you that have thyroid problems that have completely normal TSH, or I should say within clinical range. Okay, I'm going to give you a real quick lab, some hints on the labs. A perfect, let me see if I can just get to I want to get to a different page. Okay, so a perfect TSH is going to be 1.8 to 3.0. I don't really have time to develop that much. I've done it in other teachings, but if you have 1.2 to 1.8, the most common reason for that is a secondary issue. A secondary hypothyroid is generally coming from the pituitary. It's more of what's been dubbed as a pituitary fatigue. The most common thing that we see in clinical practice, here's the hypothalamus and here's the pituitary. Remember that the HPT axis, that's HPT, but you also have, here's a kidney, above the kidneys, you have the adrenal glands, and so you have an HPA axis. So one of a very common, probably the most common reason for somebody to have a secondary pituitary fatigue is from cortisol surges that come from this mechanism. Somebody has drops in blood sugar. When the blood sugar drops, the brain can't work well. So its mechanism is to send an alarm to the adrenals so you can kick out cortisol, so cortisol can marshal up some sugar for the brain. Remember, Cortisol is the wake-up hormone. It's the wake-up hormone because it does three main things. When you release cortisol, you increase your blood sugar, you increase blood pressure. This gets sugar and oxygen to the brain, so it has energy to go, and it also dampens the immune response. But when you have drops in blood sugar day in and day out, then you get too many cortisol surges, and cortisol lands on that pituitary and it fatigues it. When it fatigues it, then your TSH can wane and be between that 1.2 to 1.8. So technically, it's a thyroid function problem, but it's not a thyroid problem. And I hope that that distinction is clear, because that's an important distinction to make, that you can have a great working thyroid, and it's not the thyroid's fault. You just simply have you just simply have a thyroid function that's low. In that particular case, you would see the secondary. Tertiary hypothyroids are usually TSHs that are 1 or lower. Hyperthyroid usually lives in the 0.01 and lower than that. If you have somebody with a 0.3 TSH, this is not hyperthyroid. This is just this is a more extreme tertiary. What is a tertiary? It looks like this. Here's the hypothalamus right here, and here's the pituitary right here. Here's the thyroid right here. We have our TSH there, right? Tertiary is when something is affecting what's called the PVN on the hypothalamus. So the most common thing that I see clinically is infection. So one of the things that I will look at as a clinician, as a chiropractic internist, when I see a TSH that's lower than 1 and it is not hyperthyroid, the person's tired, they're not hyperthyroid. So if it's not hyperthyroid and I see a TSH below 1, then my first consideration is there an infection in this system? And keep in mind that it's been estimated, of course that could mean anything, but it's been estimated by some pretty good doctors that about 70% of the adult population is harboring at least one infection. So it's not uncommon for people to have infections, and if you see that, you want to go on that. I'm sorry, I didn't mean to erase that right there. So let's do this. So your TSH 1.8 to 3.0, that's a great place for it to be. 1.2 to 1.8, we're looking at secondaries. 1.0 and lower, we're looking at tertiaries. If you're above 3.0, now we're looking at primaries. So these are things where the thyroid's not putting out as well. Your clinical range is all the way to 4.5. So if somebody's at like TSH of 3.5 or 4, we don't diagnose them with primary hyperthyroid, but we can say they have a functional hypothyroid that's probably has an involvement coming out of the thyroid. Now, before we get too excited, there's two things I have to say. Number one is that TSH can bump around, so there's things that can bump it around. So if you see a TSH at 2.2 and you have hypoglycemia, don't just assume that you don't have a pituitary fatigue, because there might be something else that's influencing that TSH. So the way I would do it is if somebody has a TSH that's kind of in the zone 1.2 to 1.8, and they get hangry, they get shaky, jittery tremors between meals, they eat and they feel a lot of energy. Any of these are signs of hypoglycemia. And if that were the case, I'd say, yeah, that's probably what that is. And on the other side, if somebody's tired and you can't figure out what's going on with them, but they are tired, and you see a 1.0 or less, start looking for an infection. Look for virus. That's probably the more common, but also look for other infections, bacteria, fungi, parasites. You want to look for other infections as well. Viruses are more common to do that, but anything can do that. Anything's in fair play. If you're 3.0, if you're in that zone in thyroid where you're 3.0 to 4.5, I personally do not start using glandulars. I'm not going to use the thyroid glandular for this, because I want to get the other things working right. Remember, chiropractic internist. Chiropractic means they're going to look for the cause of the problem. And so I don't want to just give somebody a glandular, they feel better, but we didn't figure out what the problem was. And it's okay for them to feel better. The problem is, if we don't get to the root of the problem, that's going to be a temporary I feel better. And as chiropractic internists, we want to always get to the root of the problem. Okay, so that's the deal on labs thyroid. And there's one more question, one more thing, and that is, what happens if it's between 1.0 and 1.2? Well, you just have to take a look. A lot of times I see that they can be either from like hypoglycemia or some kind of stressor, poor diets, things like that, or it could be infection. So you just want to keep those things in mind. Like I said, this is not a perfect scoring on it, but this gives you some kind of scale when you're looking at thyroid cases and you're looking at TSH. Now, let's look at some of the things that you can actually see. This right here is called periorbital edema. Periorbital edema, some people call it mixed edema, but it's, excuse me, it's periorbital edema. These are this can be a common sign for hypothyroid. That's just another one. And you can see right here, see the coarse hair, and this is before and after drug treatment. And you can see he's heavier there and so on and so forth. All right, so this is before and after. That almost looks Photoshopped. Okay, here's an important one you want to look at right here. You see, you draw a line straight up from here. If the eyebrow diminishes in that lateral third right there, then that's really good indicator of low metabolism. So if you see somebody with lateral third, either thin or gone, you have somebody with a functional, you have somebody with thyroid function problems. They might be primary, it may be secondary, it might be tertiary, it could be a conversion problem, it could be a liver congestion problem, a GI problem. You could have, you know, anything, but you're going to have low metabolism happening in this person. Okay. Here's a very demonstrable. You see how that's cut off right there? That's gonna, you can see that in a, you know, you could be on a fast moving horse and see that one, right? So also you can see, you know, this thyroid. I wouldn't just look at it and say it's, you know, you want to go in and palpate it and do that and feel that. That's another one. Sometimes they have difficulty swallowing if the thyroid's bigger. Okay, that's another case right there. Here's a very common one I want you to look at right here. On this tongue, you see that? That's called scalloping. When you see those really deep scallops in there, most usually that's associated with a low functioning thyroid. So, so that's something that you really want to look at. This is called tibial myxedema right here. Whoops, sorry about that. Let me get back my pen. Okay, so this one right here. See, that's tibial myxedema. The ankle's not going to be big, but the tibia is going to be big. It's called tibial myxedema. Here's a very common sign for thyroid, and that is dry skin. A great place to look is on the heels. Also, I don't know if it's depicted here, but check the reflexes, and hypothyroid will cause a diminished reflex, especially in the Achilles heel. Also, if you have low functioning thyroid, you can have decreased circulation in the hands and in the feet. If you have decreased circulation in the hands, you can have what's called a capillary refill time that's slowed. So you put your hands here, and then it should be white for 2 or 3 seconds, and then it should bounce back. If it's 4 or 5 seconds before that white turns back to the pink color, then that's a slow capillary refill time. That's a sign of low circulation. If it's in the hands and you have low circulation, it's almost never from cardiovascular blockage of the arteries. You could have that Buerger's disease, but other than that, you're not going to really have that. The traditional Buerger's disease happen in men that smoke, you know, under 40 years old. So over here, fungal toes. You can see fungal toes with drops in circulation. And so sometimes people have low functioning thyroid, they're going to have low circulation. And if you have low circulation, you just don't have enough circulation, enough white blood cells down there patrolling. And keep in mind, fungus is always opportunistic. It doesn't fly around the air and get you like a bacteria or a virus. It only takes the opportunity if the environment is right. If you have poor blood supply, less you know, white blood cells going on, and not only that, but because of gravity, all the trash goes to the feet, all of that, then you're going to have set up for that. So those are just some things that you want to look at for thyroid. And I would like to recap thinning hair, dry skin, Of course, chronic inflammation and fatigue. I want to recap, here's some other signs, but I want to recap a couple of things. All right, so if somebody has fatigue and they have weight gain, brain fog, I want your antennas to go up and think about the possibility this could be a thyroid case. It might be primary, secondary, tertiary. It might be poor conversion, T4 to T3. Something's wrong with the liver. Something's wrong with the GI tract. It could be any of those things. You just have to search it out. Now, when you search it out, what you want to do is you don't want to just look at TSH, but you also want to look at T4 total, and T4 free. You want to look at T3 total and free. You want to look at T3 uptake. You want to look at reverse T3. That's going to give you a more complete look at what's going on with the thyroid. Okay? And here's some other signs. And let's move on. Here is a 47-year-old female, has a history of fatigue, weight gain, depression. By the way, depression also goes with hypothyroid. Why is that? When you have low acetylcholine in the brain, you're going to have slow processing speed. Slow processing speed is a recipe for depression as well. So, and she said, I just don't feel myself. So let's take a look. We're going to look at some of her blood. First thing that we notice is look at the cholesterol. The cholesterol is sitting at 217. That's fine, right? We don't have a problem with 217. But what we do have a problem with is that the cholesterol to HDL ratio down here is 2.4. Now, I'm not going to go too far into this because we've taught on this before, but here's the way we look at this. We definitely want this under 5 because over 5, it is a cardiovascular risk. Now, there's a lot more things in play when it comes to cardiovascular risk, and this is not even the most important one, but when we're looking at the lipid panel, this is what we look at, okay? So, but the perfect number here is going to be 3.1. So the perfect cholesterol to HDL ratio is 3.1. But something else happens when we see it go below 3.1. It comes generally from immune dysregulation. So you have an immune system that's dysregulating. It can be related to autoimmunes. It's not unusual. You don't see it every time. But if you have an HDL that's above 80, it's not that uncommon to see that that person has an autoimmune. If they don't have an autoimmune, they still have an immune system that's overdoing its job. You're going to definitely want to get food sensitivities on this person and work through the process to get that immune system in check. So this is a person, I'm going to say, maybe they have autoimmune, but at the very least, we're going to be dealing with food sensitivities. By the way, and here again, we've taught on this before, but LDL carries, is like a taxi cab, carries cholesterol out. Cholesterol goes out and helps the brain, helps make your hormones, helps you metabolize vitamin D, and any inflammation that's going on, it's going to go towards it, but it also helps you fight infections. So it's this inflammation, when you're going after inflammation, and it's this chronic inflammatory process that's going on, when the immune system loses the ability to kind of act normal, if you will, and it starts overdoing its job, that's when we start seeing that HDL raise like that. Okay, so we see this as the non-fasting, but we should never really see the glucose below 85. So there's two things we can see from this patient just looking at these two things. She has low functioning thyroid, or she has all the signs of low thyroid. Let's say she had the lateral third of the eyes gone, she had scalloping of the tongue, and she had dry skin. These are all signs of low functioning thyroid, maybe some coarse hair, maybe thinning of the hair. All right, so I've already seen she has an immune system that is overdoing its job, and she has hypoglycemia. These are both good reasons for something that would take the thyroid function down. So let's look further. Look down here at the bottom. You see the TSH. The TSH is in that secondary or pituitary fatigue zone, which is consistent with hypoglycemia, and that's what she has. So I have no problem saying that at least one of the problems she's dealing with is hypoglycemia. And one of the major mechanisms for hypoglycemia can be a congested liver. Because remember, the liver is the great regulator of blood sugar. We only have a teaspoon of sugar in our blood at any given time, 4 to 5 grams of sugar in our, that's a teaspoon. If you ever do those little cubes, they used to use sugar cubes for coffee, you take about 2 of those, and that's all you've got from your nose to your toes, right? If you have as much as 8 grams in your blood, you can even go into a coma. If you have less than 2 grams, coma. Now, you're not in danger really of going into coma because your body has so many systems to keep this going. But the point I want to make here is the liver is the major regulator of sugar in the body, and here's how it does it. As soon as you eat 75, 80, 100 grams, 60 grams of carbs, immediately the job of the liver is to store 95 or more percent of that. It's going to store all that sugar. Then you're going to burn that sugar up, and when you're burning that sugar up, your sugar begins to drop, then your liver lets go of the sugar. So the liver is the great reservoir. When the sugar goes up in the blood, the liver stores it. When the sugar goes down in the blood, the liver's supposed to let it go. But this is an enzyme found in the liver. It's called ALT. We want to see the 18 to 26 when it's perfect. When it's at 8, that's a really good sign that you got a fatty, bloated, congested liver. And that's a liver that's not going to be able to do its job in releasing the sugar in a timely manner. So we can see not only does this person have an issue with low blood sugar, but we can with the thyroid, but we can also see some of the reasons why it could be coming from the kidneys or from the liver. I want to make one more point here. We like to see that calcium about 9.4 to 9.7. That's a very tight range, but we like to see the protein 7.1 to 7.5. Now these aren't real low, but they're just a tick low. And when these two are low, you really want to consider the possibility of low HCl in the stomach. So you want to see if this person has burping, belching, or bloating right when they first eat, or if they eat a steak and it just lays there. These are signs of low HCl. So you're going to need to support that, because guess what? If you have low functioning thyroid, you can produce less HCl. So if you have low functioning thyroid, one of the side effects of that is low HCl. The problem with it is, if you have low HCl, nothing good happens south of there. So you're not digesting your foods properly, and it sets you up for more food sensitivities, just a whole bunch of stuff. All right. So now what we did was we looked at all the different players. So let's look at this. Here's the thyroid, nose and the mouth. I'm sorry, here's the brain. Right here's the thyroid. So we checked the T4. T4 total should be 6.5 to 12.0 when it's perfect. And this person is sitting at 5.4. If you want to look at free T4, we like to see that one about 1.1, 1.2, very tight range. So she is sitting at 1.0. So the thyroid is not putting out what it really needs to put out. But this could be because the TSH, if you remember, was low. And when the TSH is low, then it's not necessarily going to give enough oomph for that thyroid to work. Now, we go from T4 to T3, we do something called a conversion. With that 5' deiodinase, takes off the iodide. A perfect T3 total is going to be 115 to 180, and this person is sitting at 80. Okay, so keep in mind, I want you to keep this in mind. This is really important. This is kind of some heady stuff, but let's go for it. Okay, 115 to 180 and 6.5 to 12. These two are relative. So in other words, if somebody has a T4, I'll make it simple. If somebody has a T4 of 6.5, then I would expect their T3 total to be 115. If they had 12, then I expect the T3 total to be 180. So if they had 12 and then you did the T3 total and it's 120, the T3 total would be in normal range, but they have a conversion problem. There's something bothering the 5' deiodinase enzyme. So 5.4, this person has 5.4 here. So I would expect somewhere around 100, maybe 90, but they've dropped all the way down to 80. So not only do they have a secondary thyroid problem, but they also have a conversion problem. So they have two things that are really going on here. Okay, so if I were to look at this further, the reverse T3, we like to see that about 16 to 20 is perfect. So it's a little bit low. But the reverse T3, remember that the reverse T3 has this function. Here's the DNA sitting right here. I'm looking at my time. Okay. Oh my goodness. Okay. So DNA sitting right here. Reverse T3 lands on that receptor and it does nothing, but it provides a very special function in that it keeps the thyroid from just 24/7 hammering that DNA, making it make protein, because it won't work. It'll burn it out if you keep it on there 100%. So 16 to 20 represents 16 to 20% of the time that you're going to have that receptor occupied by something that does nothing but blocks the other thyroid from working. Okay. When it's at 12, it's a little low, but the reason why it's a little low is because the body innately is trying to make up for this low T3 it's getting. It's trying to say, okay, I don't need to block that. We need to get as much T3 on there as possible. Okay, so there could be more to this, but that's I think that gives you some hints. Now we look at this. We do a urinalysis and look what we find in here. She has an infection. All right, so we have three things. Immune system's dysregulated. She has hypoglycemia, probably coming from a congested liver, which is also going to cause conversion problems. 40% of the conversion of T4 to T3 happens in the liver. So if your liver is congested, you're going to be a poor converter. So that could be what's going on there. And then she has a bladder infection. So she has a UTI. So those are the three things we see going on. Her white blood cell count, that's fairly normal. But if you look at the neutrophil, lymphocyte balance, we like to see that 60%, 30%. That almost looks like a viral pattern. And so she might be having more than one thing going on, but we don't know what that would be. So the very first thing I'm going to do is just get rid of UTI and work through that and see and redo the CBC and see what happens. Now look at this. We have low ferritin. This is ferritin. If it's below 25, it is usually the earliest sign of iron deficiency anemia. So she has anemia. Our red blood cell count, we want it to be at least 4.3. Our hemoglobin, we want it to be at least 13.5. Our hematocrit, we want it to be at least 40. So this lady has, on top of everything else, she has anemia. So she has immune dysregulation, hypoglycemia, anemia, and an infection. Now, I'm painting a picture here. Is there any wonder she has low functioning thyroid? This is what I'm saying. This is right. 90%, who knows what the actual number is, but there are thousands, let me say it differently. There are millions of people running around the United States today who have low functioning thyroid. And here's what they do. They Google up fatigue, weight gain, brain fog, and ding, 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 thyroid pops up. So they go to their traditional doctor, and the traditional doctor runs a TSH, and the TSH is at 1.4. And what does the doctor tell them? Your TSH is fine. And then if they're really progressive as a medical doctor, they'll run the T4 total and it'll be sitting at 6.0. And what do they say? It's fine. It's not fine. This is, in fact, I've had and I know I've got some veteran doctors out here, some doctors I have a high amount of respect for. But anyway, you've seen this, countless times. Somebody comes in, they say, "Oh, thank God. I knew I had a thyroid problem. You're confirming that." I've been to 3 doctors, or I've been to 7 doctors, and I've had this checked by 7 different doctors. Every one of them said I had a normal thyroid. And then I have to kind of parse it a little bit and say, what you have, and the reason why they missed it is because your thyroid's actually fine. It's your thyroid function. So we're going to have to get the immune system under control, but get it regulating better. But the way to do that, the very first step to getting your immune system better is this. We're going to have to do 4 things for this immune system. Number one, let's identify your food sensitivities. Number two, let's get this blood sugar going better. Number three, let's get this anemia better. And number four, we've got to get rid of infection. Then we're going to see where everything goes. And you're going to find in this case, in the majority of these cases, you're going to find that you do these four things, and then all of a sudden, they don't have the tiredness. They don't have the weight gain anymore. They don't have the brain fog anymore, and they're not constipated. The dry skin's clearing up, and things are starting to get better. And you did nothing for the thyroid because the thyroid was not the problem, even though it was a thyroid function problem. And that's the big issue. You could, and I don't, you could do this. As a chiropractic internist, you could have a full practice just simply full of these types of cases. I'm going to tell you, people will love you because one, you are validating what they already thought, but not only that, but you're showing them how to get out of this hole. And that's the blessing of what we're able to do with these patients. Now, here's what I want to do. I have to make myself a little cheat sheet here, and I want to draw a couple of things real quick here. All right, so when we look at, let's go here. When we look at the brain, and let's look at it real quick. Okay, so we have the brain, and according to the neuron theory, there's two basic things that your brain uses for fuel. It uses glucose and oxygen. And if it doesn't have this, it can't do anything well. It's not going to regulate hormones well. You can have depression, you can have all these different things, and you're going to be kind of more toward that sympathetic dominant side, because when the brain knows that it doesn't have enough glucose and oxygen, it's continually sending alarms to the adrenals to kick out cortisol. And cortisol does its own damaging thing to the hippocampus and a lot of other areas. But over a period of time, you begin to wear out this HPA axis. And when you do, here's the next step that your body will do, because innately we got to make sure we get sugar to the brain. We got to make sure we get oxygen to the brain. So out here in the midbrain, the top of the midbrain, which is kind of the burning hot part of the brain, this is this is more of the, this is connected to the limbic system. It's connected to all those things. So when your cortisol can't cut it anymore because it's waning, and it will when you go into this HPA axis problem for a long time, then all of a sudden now the midbrain has monosynaptic connection to the medulla of the adrenals to kick out epinephrine and norepinephrine. In other words, for these are adrenaline and noradrenaline. So now the calmer approach to getting sugar and oxygen in the brain is to release the cortisol. The zipped up panic attack, anxiety, all these things, limbic brain going awry, all of these things happen much more so when this epinephrine and norepinephrine are having to be used as a substitute, because it's not really the method of choice for getting that to go. So with this lady, we just went through this case report, is that she's low in glucose and oxygen, so she's going to be sympathetic dominant, but then she's going to lose her cortisol. Once she loses her cortisol, then all of a sudden, of course, she's going to have more tendency to have colds. She's going to be more tired. She's going to be wired and tired. She's going to go to sleep at night. She's going to wake up in the middle of the night because of hypoglycemia. She's going to wake up not refreshed from sleep. And it could seem like a tangled mess that she has. But my encouragement would be, with a patient like this, don't make it any more complicated than it needs to be. Fix is the wrong way, but stabilize the blood sugar. Very simple to get the oxygen up. Just give them some iron, a little bit of vitamin C. Make sure they take it 2 hours away from eggs and milk. They shouldn't be drinking milk anyway. Find their food sensitivities, deal with those. You have a bladder infection. I like to use things like, silver, uva ursa. There's other things that people can use for that. I like to use that. In more of the chronic bladder, we'll use some D-mannose, that kind of thing. So all you got to do is just work through that, and this patient is going to do really quite well. Okay, so what I want to do here is I'm going to take just a little bit different path, and I'm going to go through. Let's do this. Because we're going through these, I actually want to go through a diabetes case study. And the next month that I do this, I will probably go through some of the rest of these, but I want to take a few minutes and actually go through some diabetes stuff. Okay, so first off, in the history, by the way, let me just ask, Dr. Annette, do we have any questions before I move on from thyroid? I will wait here for a moment because
No,
make
I
sure.
don't see any.
You don't see any questions. Wow, well, we've got a number of people on and no questions. Okay, well, I can't really see you, so I don't know if you're sleeping, but hopefully you're not. Okay, good. All right, let's get started here. By the way, I love this work. I started doing this work. As a matter of fact, I'm going to call somebody out right here because I just appreciate and honor this person so much. But I think I see Dr. Ben Bowers on the webinar. If I do, give me a thumbs up, Dr. Ben. But Dr. Ben was a teacher of mine going through the DAPC program. Did a fantastic job. And he has been just an amazing, amazing clinician. Helped a lot of people. Not only that, helped a lot of people in his practice, but he's helped a lot of doctors in teaching as well. So I just wanted to acknowledge that. So, but whenever I was going through the DAPC program, I was learning all these different things. Some things I'm teaching you here. We learned all these things, but then the cool part is I get to put this in practice every day. Do I still adjust patients? I do. But not all of them. And the reason why is because it seems like half of my patients are referred from other chiropractors, or those that aren't are already under somebody's chiropractic care. And I'm not going to get in there and say, hey, I think my technique is better than your doctor's, so I'm just going to do everything. I don't do that. There's an honor code that we do, but it's rare that I have a patient come in that is simply, I do upper cervical technique, but I rarely have a patient that comes in that's simply upper cervical chiropractic technique only. And I had one today, but I rarely have that because most of my patients, and I say most, I'm talking 90% of my patients come in, we sit down, do a consultation with them. I do a history, I do an exam. That's what we teach in the DAPC program. We have about a 10-minute, 15-minute exam that's a core exam. And then depending on what the patient has, maybe they have thyroid, I'm going to make sure to do the Achilles heel, reflex. I'm going to check their heels to see if they have dry, cracked heels. I'm going to check the lateral third of the eye, check the tongue. I'm going to check these things, look at the hair. I'm going to palpate the thyroid. I'm going to do these things as part of my exam, along with my other things. I'm going to listen to the heart, I'm going to listen to the lungs, I'm going to look in their eyes, look in their ears, do cranial nerves. I can do all these things in 10 to 15 minutes, depending on how much I talk. If I have a more extensive case, then the exam can take 30 minutes to 45 minutes or even longer. Sometimes I have to break it up in 2 days, but most usually that's the way that goes. And then I get blood work. I get a urinalysis, blood work, and I might do specialty testing. I might do food sensitivities. I might do a stool exam, hormone testing. And after going through the DAPC program, I'm qualified and competent and confident that I can go through these things and really make, a difference in people's lives. And what I love to do is I love seeing people's lives absolutely transformed. And I know in some of these cases that I'm saving lives. I know that. I know I'm prolonging lives in these cases. And one of the cool things, and this is a blessing to me, because to me, I don't want to freak anybody out. But when I'm seeing patients, this is a mission for me. This is a ministry for me. This is a way for me to serve people in such a way that gives me meaning and purpose. And I love seeing transformations in people's lives. But this does not happen without going through the work, right? And I like what the Bible says: study and show yourself approved. And one of the things that I have found is that it is important for me to study. It is important for me to put the work in, not simply just check in to my chiropractic practice, but I need to be fresh. I need to mentally be fresh so I can be growing as a practitioner. And when I do this, I can take on more difficult cases and help people with more difficult problems. And then all of a sudden, I'm not talking about me, I'm talking about you as well. We can become that doctor that just really is not replaceable. It's that doctor that solves problems for people and prolongs lives, saves lives, and do all the things that, hey, this is what we all got into chiropractic, really start with. So I want to encourage you. November 7th, and I'm gonna actually have Annette talk just a minute here. November 7th, we are starting a new DAPC program. If you've been through the DAPC program, I'm going to encourage you. There's a few of these modules you should take over. Module number 1 is a great one to take over. If you've never been in the DAPC program, I'm going to highly encourage you to do it. We're doing it right here in our clinic at Rolla, Missouri. Well, let's say you're in Wisconsin. No problem. We're going to live stream. You can do it as a live stream. And Annette, if you don't mind, could you give them information on how they could do that? Can you do that? And I'm going to turn my video off while you do that.
Okay, and you might want to peek at the questions. There's a couple questions on there that you may have already answered that popped up after we had that.
I will.
So if anybody's interested in learning how to do the webinar from home or your office, or about getting to Rolla in person to see the seminars, you can go to the website. It's prohealthseminars.com. And then under seminars, you can go to Rolla, Missouri DAPC. And you can find the schedule of events and a registration form. You can also call the office to get registered. And if you've already taken the classes, then there are concessions for people that have been through the program already. I believe there's a discount if you've already taken a class.
Yes, I believe there is. I believe there is.
$250 if you've already taken a class and you want to take it again for a refresher, and it's $395 for people who have not done it if you do it, if you register 10 days in advance. So you can call the office at 573-341-8448. You can email info@drkessinger.com, or you can go to the website and register through there.
Okay, very good. Thank you, Dr. Annette. That was very good. All right, so I had a couple questions. What about Hashimoto's? Somebody had a Hashimoto's of a TSH of 76 or something like that. Also, I had a question of, basic, what are you going to do for care? Well, let's talk about this real quick, okay? So when do you use glandulars? That's actually a really good question. When do you use glandulars? Okay, well, when we look at thyroid issues, here's the brain, the nose, and the mouth. Here's my thyroid. So there are, and we teach this in the DAPC course, there are 6 patterns, 6 major patterns to low functioning thyroid. You can really get into the minutia, and there's over 30 subcategories, but there are 6 major categories. One category is what's called primary hypothyroid. Primary hypothyroid, we said 1.8 to 3.0 on the TSH is normal. When you are between 3.0 to 4.5, then that would be called a functional primary. Functional primary. When you're over 4.5, then that is a primary hypothyroid. It is the primary hypothyroid that will actually benefit from thyroid glandulars. I don't use, well, I will have rare exceptions, but hardly ever will I use a thyroid glandular in the normal case when the TSH is lower than 4.5. But having said that, there's one other thing that I will do. If somebody has Hashimoto's, and somebody just said they had TSH of 76, there's 2 products out there. One is GTA and GTA Forte, and that one is from Biotics. Whoops, that one's from Biotics. And then there's another one that's called Echo, either 37 or Echo 125, and that comes from Professional Health Products, PHP, out of Pennsylvania. Now, if you want, you can call that number that Dr. Annette gave, and you can ask where these come from. I have a tendency to use a lot more GTA, but some people just do better when I do the other. But I will start with the GTA Forte. Now, having said that, if somebody has Hashimoto's, TSH can look like anything. It could be 0.5 all the way up to, I've seen 125. So you could be at 0.5 to 125. If somebody comes up with Hashimoto's and they are at 2.0, you know, they're tired, they don't feel well, right? In that case, I will use at least a low dosage of thyroid glandular. And the rationale is this: if you give them a glandular, then the white blood cells will attack the glandular to some degree, and it will reduce the amount of attack that's happening to the thyroid. So the glandular is like a false flag. So you put it in the system, and if they don't need it that much, just put a little bit in the system, and then maybe out to 2 GTA, regular GTAs. Unless they're tired, if they're feeling tired, and if they're at 2.0, then I might even go to just to 1 GTA Forte. Go ahead and try it. Now, the one thing, if you give glandulars and somebody feels an inward trembling, or they can't sleep, then you've given them too much. Also, if you give them a glandular, make sure they take it on a full stomach, or it'll give them a pretty good sized stomach ache. So those are the things. Now, as far as care for these guys, let's look at this right here. It depends on what's going on. If it is a pituitary or a secondary issue, I'm going to find out what that secondary issue is. If it's hypoglycemia, then I'm going to do things like make sure they're taking a protein powder in the morning, make sure they're off sugars, right? And make sure they're snacking in between. And I'm doing some kind of cleanse on the liver to get it uncongested so that the sugar can regulate, okay? If it is tertiary and it's coming from an infection, well, I have to go after the infection. Keep in mind, most of these are viruses, but it could be something else. Our viral approach, which is a whole immune system or an infection module, but in basic, I'm going to use herbals like olive leaf extract. I'm going to use homeopathics, as long as they're not Amish, because Amish folks and Mennonites, some of them think that homeopathics are witchcraft. So you want to watch out for that. So I'll use homeopaths. I can also use vitamin C. I can use something called monolaurin. Lauricidin is a brand name. So I'll use these things. But keep in mind, you don't kill a virus, you get it in dormancy. So you have to get the system tuned up. You got to make sure the liver's working good, the blood sugar's good, they don't have anemia. Get rid of food sensitivities, eliminate those. Make sure the GI system is working, well. Make sure there's no other infections going on. Then once you do that, now your herbals and your homeopathics and your monolaurin and maybe your vitamin C, quercetin, and things like that are going to have more effect at getting the virus in dormancy. If it's a conversion problem, so in other words, you've done your total T4, you've done your total T4, and you've done your total T3, and you know that there's a big drop from T4 to T3. Well, we have a list. If you have poor conversion, then here's some things you want to think about. Low cortisol surges, I should say. Inflammation, they're inflamed. Liver congestion, insulin resistance, a poor microbiome, low in selenium, low in zinc, or poor sleep. There might be more than that, but there's you a list to start working off of. There's 8 things that can cause that enzyme not to work right. So look, do they have cortisol surges? That could come from hypoglycemia. Are they inflamed? Do they have food sensitivities, GI tract? Do they have infections? Do they have other things causing inflammation? Are they sensitive to nickel? Do they have parasites? What's going on? What's the liver doing? Is it congested? You do that through palpation, listen to the symptoms, looking at the enzymes in the liver and those kind of things. Do they have insulin resistance? Work through that. Do they have a good microbiome? Work through that. Are they low in selenium, zinc, or do they have poor sleep? You work through that. So I can't really go through each one of those, but I just want to give you a list that if you have poor conversion, those are the things you look at. If it's Hashimoto's, then you have to keep in mind that it is not a thyroid problem, right? That's the first thing to understand, that if it is Hashimoto's, it is not a thyroid problem. It is an immune system problem. If it's an immune system problem, I'll give you a very down quick and dirty thing. First thing is you have to identify what's triggering the immune system to act weird. Okay, so the immune system has lost its tolerance, so now it's attacking the thyroid. By the way, in the United States today, the #1 autoimmune is Hashimoto's. So first two things I'm going to think about are food sensitivities and infection. Those are two very common triggers. That's one. Number two, you're going to have to deal with leaky gut. 80% of your functional immune system is in the barrier system down in the gut. And so when you have autoimmune, you always have to look for leaky gut. Go through a process where you know how to stabilize that. And I may do a whole webinar just on that. Like we do webinars on a lot of things. And the third thing is just tune the system up. Tune the system up. Make sure, like I said a while ago, blood sugar's good, no anemia. There's no, the liver's working good, the GI tract's working good. And then on top of that, there are some things that have been shown that have been good to calm the immune response. One would be glutathione. Glutathione is very powerful, and we like to use liposomal glutathione, or you can use it as a nebulizer. Fish oil is really good at calming down the immune system, especially the EPAs. Vitamin D can be good, but don't get them up to 90, 100, 110. That's too much. I actually like to see it around 40 to 50, maybe 60. In these cases, bump it up a little higher. Curcumin, resveratrol. Okay. So also, there's a product from Apex that's called Nitric Balance. That's also a good one. Okay, Nitric Balance. So my go-tos when I first start with somebody with an autoimmune and I need to calm the immune system down, are they going to be at the top three? Fish oil, glutathione, nitric balance. But I also will look at vitamin D, and I will, after we work with the top three, then I'm going to introduce curcumin, resveratrol, and just see if it makes a difference for that patient. Okay, so are there any more questions on there, Dr. Annette? Is there anything else out there?
Nope.
Okay, well, I thank you guys. Here, let me get back to here. I thank you guys once again for staying in here and being attentive. I love doing this stuff, and I love seeing people's lives transformed. If you're interested in the DAPC program, then I encourage you just to get a hold of us. Pro Seminars, is that proseminars.com? Is that what that is?
ProHealthSeminars.com.
Oh, I'm glad you got it. ProHealthSeminars.com. Okay, guys, thank you so much for watching. Next month, I will go through either the cardiovascular or the diabetes. I didn't realize that once again I was biting off more than I could chew. Dr. Annette, can you turn it off?
Yep, I can do that.
Okay, very good. Thank you, guys. I look forward to seeing you guys.